So the presentation of ALL is pancytopenia. AML can also present with features of pancytopenia. There's one other important disease that present with features of aplastic anemia. So how you are going to differentiate between acute leukemia and aplastic anemia? Remember that in aplastic anemia, there's destruction of the bone marrow due to some virus or due to autoimmune condition. So there will be no production of any of the cell line, including RBC, WBC, and thrombocytes. So the peripheral smear in aplastic anemia, it will be normal. It will not show any abnormal cells such as myeloblasts or lymphoblasts. This is one difference between these two. And the definitive diagnosis of aplastic anemia or ALL that is made on bone marrow biopsy. If bone marrow biopsy show myeloblasts, then it will be acute myeloid leukemia. If it shows lymphoblasts, then it will be acute lymphoid leukemia. And they simply mention that on bone marrow, blast cells are present. Then you will decide about ALL or AML on the basis of age of the patient. If a patient is a child with blast cells on bone marrow, then it will be ALL. And if a patient is an adult with blast cells on bone marrow, then it will be AML. And the bone marrow biopsy in case of aplastic anemia, it will show a hypocellular bone marrow. Hypocellular bone marrow. The bone marrow is replaced by adipocytes. So hypocellular bone marrow that is replaced by fat cells. So if there are fat cells on bone marrow, then it is aplastic anemia. So you can differentiate between aplastic anemia and leukemia on the basis of peripheral smear result, peripheral film of blood, and also on the basis of bone marrow biopsy. So remember these two differentiating point between aplastic anemia or leukemia, because in Plab 1, whenever you see pancytopenia, you will think of these two things. One is aplastic anemia and the other one is leukemias.
In acute leukemia, PTF, they will show like pancytopenia, right?
Can you speak a little louder, please?
In acute leukemias, the peripheral blood film will show pancytopenia.
Yes.
And aplastic anemia will show what? Nothing, normal.
Full blood count will show pancytopenia, and peripheral blood film will show abnormal white blood cells.
Okay,
in case of leukemia. While in case of aplastic anemia, we have discussed that in leukemias there is formation of abnormal white blood cells. That's right. So the peripheral film in leukemia will show abnormal WBCs. And in case of aplastic anemia, because there is no formation of the WBCs, and the WBCs that are formed, they are normal, they are not abnormal. So the peripheral film in case of aplastic anemia, it will be unremarkable or a normal peripheral film. Is it clear?
Yeah, doctor, clear.
Remember that SLE, vitamin B12 deficiency, myelofibrosis, hypersplenism, they can also present with features of pancytopenia. But normally, when you see pancytopenia in Plab 1, you will think of leukemia, acute leukemia, or aplastic anemia. So a bone marrow biopsy is showing blasts confirm the diagnosis of acute leukemia. So it is very unlikely that lab questions would ask you to differentiate the AML from ALL using a specific test. Yet, if a child is presenting with the features of pancytopenia, ALL would be the most likely diagnosis because it is the commonest childhood leukemia. Complication of ALL is commonly it is a lymphadenopathy. The treatment is supportive care in the form of blood and platelet transfusion, and for neutropenia, IV antibiotics. Chemotherapy is the main treatment. So, what is the prognosis of acute lymphoblastic leukemia? If it's diagnosed in adults, then the prognosis is poor. So it's a poor prognostic factor. Presence of Philadelphia chromosome in ALL is also a poor prognostic factor. CNS sign is also a poor prognostic factor, and white cell count of more than 100 is also a poor prognostic factor. So now a short summary of acute lymphoblastic leukemia. It is common in children. It presents with features of pancytopenia. Peripheral blood film will show abnormal white blood cells or lymphoblast cells or blast cells, as well as bone marrow aspiration or bone marrow biopsy will also show numerous blast cells. And as we discussed in the exam, pancytopenia is either ALL or aplastic anemia. So let's do an example. A 4-year-old child presents with fever, pallor, tiredness, and decreased appetite. There are deep cervical lymph nodes, but not tender. Remember that in leukemias and in lymphomas, lymphadenopathy is painless. But in infections, such as in viral infections or in TB, lymphadenopathy will be painful or tender lymphadenopathy. If lymphadenopathy is painful, then it's infection, and if it's painless, then it's either a leukemia or a lymphoma. There is splenomegaly. There is a history of recurrent throat infection. So a child 4-year-old who present to you with pallor and tiredness, which are features of anemia, history of recurrent infection, which is a presentation of a decreased white blood cell count or abnormal white blood cells. His HB is 9, so anemia is confirmed on peripheral blood smear, and WBC count is 2. So it is most likely acute lymphoblastic leukemia. The diagnosis is acute lymphoblastic leukemia. The diagnosis will be confirmed on a bone marrow biopsy, which will show numerous blast cells. So now a very important point. If in the Plab 1 exam, the STEM has a patient who present with pancytopenia. Now, what are the clinical symptoms and signs and symptoms which will allow you to choose acute leukemia or aplastic anemia? Remember that in leukemias, there is formation of or excessive proliferation of lymphoblastic cells or myeloblastic cells. And these cells can invade or infiltrate the lymphoid organs, liver, and spleen. While in aplastic anemia, there is no formation of these abnormal white blood cells. Because of bone marrow failure, these cells are not formed. So if there are no cells, there will be no invading of the lymph nodes or liver or spleen. So if the patient is present to you with pancytopenia and there is lymphadenopathy and hepatosplenomegaly, then it will be acute leukemia. And pancytopenia without lymphadenopathy and hepatosplenomegaly, it will be most likely be aplastic anemia. So this is a third differentiating factor on the basis of clinical signs and symptoms. The first is that we can differentiate between aplastic anemia and leukemia on the basis of a peripheral film. Peripheral film will be normal in aplastic anemia, while in case of leukemia, it will show blast cells or abnormal white blood cells. Bone marrow biopsy If bone marrow biopsy shows numerous blast cells, then it is acute leukemia. And if it shows hypocellular bone marrow that are replaced by fat cells, then it will be aplastic anemia. The third point on the basis of which we can differentiate between aplastic anemia and acute leukemia is that if lymphadenopathy and hepatosplenomegaly is present, then it is most likely acute leukemia, because there is no lymphadenopathy or hepatosplenomegaly in aplastic anemia. And the reason I have already told you that because there is no cell lines are present, so there will be no infiltration of the lymph nodes or liver or spleen. So a 15-year-old girl presents with chest infection which was treated. A few days later, the girl returns with another chest infection. Upon looking at her labs, you find that there is always mild anemia and thrombocytopenia. So how will you confirm your diagnosis in this patient? A 15-year-old girl presents with chest infection. So a 15-year-old female with recurrent chest infections and thrombocytopenia and anemia.
Bone marrow biopsy will confirm the diagnosis.
First, we'll do the full blood count and then the peripheral.
Full blood count is already done, which shows mild anemia and thrombocytopenia.
Right.
So
Next is the peripheral.
yes, the initial investigation can be a peripheral film, but how will you confirm the diagnosis? What
Uh,
investigation?
bone,
Yes,
bone
bone
marrow
marrow biopsy. Because in this scenario, we cannot differentiate between if it's a aplastic anemia or if it's lymphoblastic leukemia or ALL, because no differentiating the findings of peripheral film are all not given, and there is nothing mentioned about lymphadenopathy or hepatosplenomegaly. So we'll confirm our diagnosis on bone marrow biopsy. Remember that WBCs in ALL might be normal. The WBC count may sometimes be normal or it can be high or low as well. But the patient can still develop recurrent chest infections or recurrent infections because these WBCs, the WBC count may be normal, but their function may be disturbed or they will be dysfunctional. So it's not necessary that pancytopenia will be given always. This is a peripheral blood film which is showing lymphoblasts. Lymphoblast cells, you can see these 1, 2, 3, and 4. These 4 are lymphoblasts. They are cells with a large nucleus. This blue color or purple color is basically the nucleus, and there is no cytoplasm. You cannot see any cytoplasm. So this is how the brass cells will look like in case of lymphoblastic leukemia. Large lymphocytes, large cells with large nucleus and a scanty cytoplasm. Now the next leukemia is acute myeloid leukemia. So the presentation of acute myeloid leukemia is similar to acute lymphoid leukemia or lymphoblastic leukemia, that is anemia, infection, and bleeding. Bone pain can also be present because of excessive proliferation of blast cells in the bone marrow. Bone pain can be present in both of them. CNS signs can also be present. Hepatomegaly, splenomegaly, they can also be present. Lymphadenopathy can be present. So you can see that all the presentation is same as ALL. Clinical signs and symptoms are same as ALL. Gum hypertrophy can sometimes occur in AML because these myeloblastic cells they infiltrate the gums, which lead to gum hypertrophy. So this is a feature that is different from ALL. All the other features are same. Investigation will show uh, a high or a low or a normal white cell count. There will be blast cells in the peripheral blood film, and bone marrow biopsy will show blast cells as well. Complications include infections, tumor lysis syndrome. We'll discuss the tumor lysis syndrome at after discussing all the types of blood cancers. Treatment is same as for ALL. So the presentation and everything, blood findings are even same in both the cases, in ALL and in AML. The only differentiating point on the basis of history, on the basis of clinical sign and symptom is that uh, lymphoblastic leukemia it is common in children and myeloid leukemia it is common in adults. Now there are some other differences that a peripheral blood film will show myeloblasts with or rods. There will be rods that are present in the myeloblasts. Let me show you diagram. So you can see this in this diagram that this is a myeloblast. One difference between myeloblasts and lymphoblasts is that myeloblasts are larger than lymphoblasts. You can see that this myeloblast, this is larger than these lymphoblasts, and they have a very little amount of cytoplasm, but myeloblasts they are larger than lymphoblasts and they will contain or rods. You can see this rod type structures. So if it's mentioned, if features of pancytopenia are given and age is given, and they mention that there are or rods visible on a peripheral blood film on or bone marrow biopsy, or they mention that they are myeloblasts, then your diagnosis will be AML, no matter whatever the age of the patient is. If these findings are given, then you will select acute myeloid leukemia. Then you will not look at the age of the patient. But if this specific finding of myeloid leukemia it is not given, then you will look at the age to select your diagnosis. Is this point clear to everyone?
Yes.
So, or rods on blood film and gingivitis or gum bleeding. They are specific for AML. All the other features or presentation or peripheral blood film findings or bone marrow biopsy findings, uh, they will show numerous blast cells in both the cases. So one difference is this one, or rods on a blood film, gingivitis, and the second difference is that myeloid leukemia is common in adults and lymphoid leukemia is common in children. Children up to 15 years of age, pancytopenia and blast cells is ALL. Adults, or rods and blood cells is AML. So in short, if you see numerous blast cells on bone marrow biopsy and the patient is a child, then it will be ALL. And if the patient is adult, then it will be AML. Now we are done with acute leukemias, acute lymphoblastic leukemia and acute myeloid leukemia. They are common in people with age less than 40 years. Now our next topic is chronic leukemias.